And a very good evening to you. I am Lisa Lord, and my special guest is podiatrist Miss Simone McConnie. Miss McConnie, thank you so much for joining us on your program.
What can I say? Thank you so much for having me, for even reaching out to me as a podiatrist, because we're kind of elite. So
you are elite, indeed. That's why we want to discuss podiatry. No, you've been a podiatrist for about 30 years now.
Correct.
But the field,
1993.
I was 7 years old, so a while. Yeah. So looking at podiatry, we've always been told it surrounds that branch of medicine that deals with the feet. However, it extends beyond the feet. So I want you to explain for the public, what is podiatry?
Okay, so first of all, I'm going to say Barbados has come a long way, because when I first returned from the UK and I went out and people said, "Where are you?" I say, "Podiatrist." And I go, "What is that?" Now they actually know exactly what you say, and they say, "Oh, that's something to do with feet, right?" And I say, "Yes." And I say a lot to do with feet, because if you want to put it in a nutshell, it is anything you can think of mobile, things to keep you mobile. So it doesn't matter what it is. We know we know how to walk, we know to stand for long periods of time. So podiatrists are there to help keep you moving. So we're a specialty profession dealing with the lower limb. Our study of field deals with from the hips down. Our anatomy that we do is of the whole body when we're training. So we do a lot of the pre-med training, just like what the doctors would do. But then we go straight into lower limb anatomy and looking at functionality of the lower limb. And all of the diseases and all of the specialties related to walking, we also specialize in. So when we think of feet, we think of the elderly, that's one. We think of MSK, what we call musculoskeletal problems. So that will be sports injuries, sports related stuff. Then we go into any kind of orthopedic type related things with the lower limb, the knee, back pain can be directly related to your alignment of your feet. And then we have children. So we have a section of pediatrics, diabetes, wound care. And I think because we are so multi-purposed, I think people get a little confused as to what we actually do. Because, it's kind of like one of those, I always think out of the joke where they say, "Oh, but I thought y'all only do diabetic feet." And we go, "Yeah, we do that too." And then, someone says, "Oh, we do wound care." Well, yeah, we do that too. You do nail care? Yeah, we do that too. We do skin care? Yeah, we do that too. You look at how people walk and realign their bodies so they no longer get foot pain. We do that too. So, podiatry is defined as a profession that specializes in lower limb conditions and the treatment and management thereof. So we can span anything related to how do we keep you ambulant. And that is not only as a child, but as you get older as well. So if you think of a lifetime of your whole life, we can be present at every stage of your life, because there's certain disorders that become more relevant at different stages of your life. And you can also look at us as, I guess, practitioners that are very versatile from the perspective that, you tend to see a lot more women doing podiatry because of the versatility of it, in that you can work half days, you can work part-time, and you can still raise a family. So a lot of women do get into podiatry as a result, but it is actually a lot of men do podiatry, because podiatry has different phases. So this is something that I've learned over the years that it's also a little confusing for most people. And I think it's how podiatry was sold in the beginning. So I think we were sold as, "Oh, y'all cut toenails." Well, if you think of it, do we go away for 4 years to learn how to cut toenails? I think we all grew up cutting our own toenails. So I don't think that we need to train for 4 years to know how to cut toenails. So we don't just cut toenails. And the thing about toenails, even if we were to look at toenails by itself, that in itself, there could be ischemic diseases going on that causes nail dystrophies. So it's not just about cutting toenails either. It's how you cut toenails. And you can have different shapes of nails. So depending on the shape of the nail, you may not want to cut it. You might want to file it. Because if you have a nail that's kind of a semicircle, so some people have nails that are flat and some have them that go around corners. You know, some are thick, some are easy to cut, some are not. So if you really want to talk about nails, we could. But the reality is, I think we were sold as nail cutters. So I think the medical profession misunderstands what we do. And the challenge of practicing in somewhere like the Caribbean is, first of all, you've come into an area that has been predominantly monopolized by the general practitioner being the main player. And now you have a specialty which they're not quite sure what we do, as I said before. Along with that, I believe that, you know, in the Caribbean, we cannot specialize. So in the UK, you may have verruca clinics. So verrucae or something else, which are warts you get in the feet. Some podiatrists will specialize in that. That's all they see all day. Some people will specialize in wounds. Some people will specialize in a diabetic foot clinic. Some people will specialize in children, pediatrics. Here, we kind of have to know some of everything because some of everything walks through our door. And we have to be able to be multi-purposed enough to either refer on, treat, and collaborate as is necessary. Obviously, we have patients at the beginning and forefront of what we do.
Well, let's look at some of the conditions, some of the popular conditions that you might see here in the clinic, starting with corns, calluses, and bunions.
Right. So I would say the most popular things we do get are like corns. And I'm going to say about corns only because there's corns and then there's abrasion of the skin. So a lot of women who wear those pointy-toed shoes get these discolorations on their tops of their toes.
Why are you looking at my feet?
And I did? Oh, there. Yeah, so so those discolorations are really because of the positioning of your foot in the shoe. Mm-hmm. So we'll get many women coming in and saying, I have a corn on my toes. But when you really examine it, it's just a fibrous area that has come up because your body is trying to protect that abrasion of the narrow toe box or the very shallow toe box of their foot. And, you know, if I had a penny for every time I told someone what their true shoe size was, because a lot of women I would say, oh, people, not just women, what size shoe do you wear? Most of the time, they're at least 2 shoe sizes smaller than they're supposed to be. So they would say, oh, I've worn a 9 all my life. And I'm like, well, look down many times I have to go, come, look down at this measuring stick, and you will see that you're actually a 10.5 or you're an 11. And they go, oh my gosh. But they only get it when they see it with their own 2 eyes. And a lot of the times women, we have a lot of Caribbean women with pretty big feet, and they are tall and they're big women. So you can't have small feet. So just be proud of your feet and, you know, wear the right size, and that will reduce your foot problems. A lot of women say, well, don't tell me the size. Just let me know what I need to buy as in. I said, but you have to look at footwear and sizing as a foundation for foot problems. So if we're looking at footwear alone and looking at some of the common anomalies that we get, the squeezing of the foot in the shoe causes rubbing of the little toe to the 4th toe, and you can get interdigital corns. Or if you have a very sweaty foot, some women get interdigital maceration along with the interdigital corn. So when you open between the 4th and the 5th toe, you have this white.
Yes.
And sometimes it's like almost if you put a pea down in there. So it's like a white build up between the toe. And that can be a combination of either the shoe being too tight, well, it's always the shoe too tight, but a combination of that and the maceration. And of course, if it's very moist and the frictional forces, then it causes it to be a harsher force. So it builds up. So it becomes a vicious cycle if you don't actually change the sizing of your shoes. You can get the calluses on the top. You can get the corns on the top. There's a difference between a corn and a callus. A corn is more of this kind of action, so this kind of action happening on the inside of the shoe, versus callus, which is this kind of action happening on the inside of your shoe. And if we go back to footwear again, showing you the foundational cause being footwear, high heels, if you're in high heels for any length of time, you start getting pain on the ball of the foot. You get calluses on the ball of the foot. Some women get calluses on the inside of the big toe or on the tips of the toes. So corns and calluses presenting in those kind of ways tend to be something that's very commonly seen. And you will find that if you think of calluses and corns as protection, it means that you cannot tell me that your shoes are fitting you fine and you're comfortable, because if they are, you will not have the corn and the callus.
They're new, so I'm not breaking them in as the people
that
say.
does not work. Breaking in shoes, you should never have to break in a shoe. So wear the right shoes. So, you know, from a size, I would say your shoe size and your foot size are different. So, you know, you might have a size 8 foot, but you may wear a shoe that is anywhere from, so for example, I have a size 8 foot, but I wear a shoe that's a 7.5 and I can go up to a 9. So some of my sneakers are a 9 because it's down to the fit. To the fit of the shoe, because you have to remember that your foot is your foot, but shoemakers all use something called a last to make their shoes on. So you will find that depending on where the shoe is made, who it's made by, what company, what part of the world. So for example, some Italian shoes tend to be a bit smaller because their average size foot is smaller. So their lasts are smaller. So you will find that they tend to be a lot more narrow, etc. So it depends on what part of the world the shoes are being made. And I always suggest that it doesn't mean you can't wear that style, but just be respectful of your feet. Because at the end of the day, you're going to not be just putting the shoes on to sit down. You're going to be putting on the shoes to do walking around in. So this is where, like, you know, when we're talking about, so if you're looking at common foot problems, which is something you asked me about, and I look at footwear, I think if we got the footwear right, it would help with some of the common foot problems we get. And of course, when you look at things like clawed toe deformities, some of them, they're clawed toes, they're overlapping toes, they're bunions, there's ball of the foot pain. Some of these things come back to footwear. You know, I've had 1 or 2 people who've come in and I highlighted their footwear and they were like, I can't believe I never thought about footwear being causing so much foot pain. And all they did is go into the right shoe size, foot pain goes away. Wear and tear on footwear as well. So if we're looking at runners and athletes and those kind of people, you know, things like heel pain, arch pain, Achilles tendonitis, plantar fasciitis, even the same ball of foot pain. So if we look at Morton's neuromas, Morton's neuroma comes from the shoe being a bit too narrow. Mm-hmm. So it doesn't feel narrow to you, but it is too narrow. So you do that long enough, there's a nerve that runs between the second and third, or third and fourth. Either one can become inflamed, and the nerve gets inflamed, it swells up, it burns, it hurts, causes pain. So when I have my patient with ball of foot pain and we find a Morton's neuroma, now I usually use diagnostics in order to make sure that it is a Morton's neuroma. They will bring heaven down and say, but my shoes are comfortable. And I'm always like, but it can't be comfortable if your feet are too tight, your foot is too tight. And once we then negotiate on size and negotiate on fit, and the pain goes away, we're then best friends. But in the beginning, just hearing that your shoe size is wrong. So you're looking at how footwear can really cause some of the challenges. And when it comes to like runners and so forth, as I said before, sneakers are no longer made to last forever. And based on the wear and tear of the sneakers, you should be changing your sneakers every 500-600 kilometers. So if you're looking at that, you're thinking about maybe changing your sneakers. If you were someone exercising and running out there every day, you know, you're probably needed to be changing your sneakers every 7 or 8 months. My standard, I tell most people, is at least change them once a year, because even if you push it. But I have some people who buy a pair of sneakers and they never change them.
Right.
Or in us becoming more active, some of us don't want to be active because when we go to be active, our feet hurt. But maybe it's not just the sneaker. It may be your body. It may be how your alignment is. So it may be that you're knock-kneed, or you're bow-legged, or you know, you have very flat feet, or the shoe is not fitting you well. So you may find that this then predisposes you to the same Achilles tendonitis, plantar fasciitis, calf pain, knee pain, back pain, you know, limb length discrepancies. There's some people that suffer with their back for years, and all they needed really is not just a chiropractor, because they do have a role, and we all have a function. We all have to work together as healthcare practitioners, and for the benefit of the patient. That's how I see it. So you may get your alignments, or you see the osteopath for your alignment, but then you should really be wearing an adequate heel raise. And I'm not really a fan of just putting a little wedge under people's feet, because if they have what we call like a rear foot varus, which is where, you know, your foot rolls out a little bit. So when you stand up, your foot rolls out. If I just put a heel raise on there, all I'm doing is I'm moving your forces from your rear to your forefoot, and then I'm causing another problem. So things like orthotics so I use the word orthotics now, because here you can go anywhere and buy a pair of inserts. But inserts, and lots of people with foot pain will say, oh, I went and bought a pair of inserts, or my doctor told me to go to the thing and get inserts. So inserts are what you can buy over the counter. And if you have a rear foot varus and you wear a arch support, you're actually making your situation worse. So then I see a lot of people presenting with peroneal tendonitis, pain on the outside of the legs, pain in the knee area. So another role that we play as podiatrists then is looking at you. So we often do what we call gait analysis, and we look at how you walk and how that mechanism is feeding into the concern that you have. So if you have plantar fasciitis, some people have plantar fasciitis, but they don't actually have a flat foot. They actually have a rear foot varus. And once we fix the rear foot varus, we actually fix the mechanics of the foot. So the coordination of the foot becomes better and the pain settles down. So it's a combination, and then we would use physio. So we would refer to a physio, and we'll work in collaboration with a physio. And all the recent studies are showing how important it is not just to do the orthotic, stick that in a shoe or put a steroid injection. And actually we don't do steroid injections anymore for these things, because they actually do not fix the problem. They may settle it, but they don't actually fix it. So what my experience over the years has been is, if you've had a heel injection for a heel spur in the past and it flares back up, getting it to resolve is so much more difficult. So it's better not to have an injection. But the problem is, when you're in a lot of pain, you want something and you want a quick fix. But I think being fair to your bodies, we're not computers, and we need to be thinking of the fact that we need to give our bodies time to heal as well. So 6 to 8 weeks is kind of the timeline with any of these tendinitises that we're looking at for healing. But then most importantly, as I started to say earlier, the studies are showing the importance of re-education of those tendons. So based on how you're walking, the re-education of those tendons, in order to ensure that when you go back to functionality, walking, etc., that you can do it without having a reoccurrence of the problem. And that's where customized orthotics come in, because we do like a gait analysis, gait scan, gait load. So we kind of know what your challenges are, and then we add a prescription to that. So it's just almost like a pair of glasses to help bring that prescription, bring you back to being able to see well, will bring you back in being able to be in balance and for your body to function well. And that takes your pain away. So that's that other category. And then we can go then very well into diabetic feet, wound care, which is another thing we see a lot of.
And I want to talk about diabetic feet a little later, but I want to go back to looking at some of the other conditions. And a lot of people complain about pain in their instep.
Yes. So instep, arch pain, plantar fasciitis, tendinitis in the area, all of those sit in a similar box, and they all come again from what I was saying about functionality of the foot. So if everyone in a room took all their shoes and socks off and looked at each other's feet, none of our feet are the same. But when we put our shoes on, they're the same shoes you have to choose from. So one of the questions you asked me before was, but if I wore a size, I'm a size 9. If I wore a size 10.
Yeah, we discussed that off camera.
Right? Mm-hmm. So if I wore a size 10, my foot slips out of the shoe.
It's gonna rub.
And I would say that means the size shoe, the style shoe might not be the right style for you. So you may have to look at a different style. And I know fashion is important, but some of us have a narrow heel, and some shoes don't have a narrow base for that heel. They don't have an accommodation for that narrowness of that heel. So you may have to wear something that's more secure to lock your rear foot onto your forefoot so you don't get that movement. So this is where the style shoe then becomes very important with regards to what you wear to stop that rubbing and that friction. So that is always a confusion with persons, because they find it. I have always had lots of people that say, you know, I am so challenged with knowing what shoes to wear. No matter what I wear, my feet hurt me. I get arch pain all the time. And then I put this thing in the shoe for the arch pain, and it's still hurting me. But that is because you probably just bought something off the shelf, you put it in your arch. You may not even have put it in the right way, because that's the other thing I've found. You know, people go and buy. I know we like DIY. I know visits to podiatrists are expensive. I know all of that. But I mean, obviously expenses come down to other factors that don't come to us. It's not like, you know, it's the electricity, it's the taxes and duties that we have to pay on these things, you know. So it comes in a full circle. But the reality is it's not just buying something off the shelf and thinking that you're fixing your arch pain, because your arch pain may not be just coming from your arch. It might be other things that may be causing it too, such as, you know, it may be, you may have a plantar flex first ray that's getting in the way, sesamoid problems. And some people say to me, their arch is hurting them. Mm-hmm. But when I ask them to show me where their pain is, it's actually not in that location at all. It's on the other side of the foot. So it's also, how do we perceive the anatomy of our foot? Or some people say that my foot is hurting me, and when they show me, it's actually their leg that's hurting them. So, and the leg is the piece between the knee and the ankle. The foot is the piece between the ankle and the toes. So sometimes when people are speaking to me, I have to be very careful with them, trying to explain exactly where is hurting you again. And sometimes it's very unrelated to what you think you may have diagnosed yourself to having. So I would say plantar fasciitis is a term that is heard a lot of, and it's the plantar fascia at the bottom of the foot that's causing the irritation. But we always have to look at, why is it irritated? So you may say, I see a lot of people who like stand for long periods of time, yes, you know, and in their job, they do a lot of standing. But when I then get them to bring their footwear in, and I always say, you know what, we're the one people you could bring shoes in. We love shoes. So you bring your shoes in so we can actually see what you're wearing. And some people are wearing the poorest shoes to stand for long periods of time. And sometimes all I do is fix them by putting them in the right pair of shoes, and the pain goes away. So with regards to the arch pain, it really depends on that person, their anatomy, what's affecting that arch. It may not be as simple as just arch pain.
Well, Ms. McConnie, we have not even scratched the surface. Still a lot more to discuss. Stay with us. You're watching One on One.
As Barbadians prepare for the Atlantic hurricane season, here is some information about shelters. Shelters are listed in two categories. A Category 1 shelter may be used during a hurricane or other hazard event, while Category 2 shelters may be used if they are still in a reasonable condition after a hazard event or disaster. Persons are advised to make their way to shelters well in advance of a storm's arrival.
Hi everyone, I'm Dr. Danielle Reed-Melillo and I am a general physician, and today we're going to talk about obesity. Obesity is an NCD. An NCD is a non-communicable disease. Basically, that's an illness that cannot be passed from one person to another, such as diabetes, hypertension, or cancer. In contrast, a communicable illness can be passed between one person to another, such as COVID or the common cold. The BMI is the body mass index. Obesity is defined as a BMI over 30, and overweight is a BMI over 25. Your body mass index can be calculated online or at your next doctor's visit.
Hi, I'm Carl Padmore, Public Relations Officer of the Sanitation Service Authority. Maybe you would have witnessed roadkill, or you would have passed the highway or a byway and seen a dead animal. We want you to report it to one of the numbers coming across the screen. We'll come and we'll remove that dead animal. Also, if you have an animal who has passed away at your home, we prefer you to do it the legal way than to throw it into the gully, contaminate the gully, and then we have problems. Barbados, we love our environment. Let us care our environment. Therefore, the correct way to dispose of dead animals, call the number coming across the screen. We are here to help you. The SSA cares. Clean thoughts, clean living, clean nation.
The Barbados Police Service is a dynamic organization which caters to the needs of all residents by providing excellent customer service within our communities. We are excited to inform you that we are recruiting new members to our ranks and welcome your participation.
We are building the Barbados Police Service within our communities. Are you smart, skillful, motivated, ambitious, reliable, and talented?
Smart to fulfill your life's dream.
Smart to chart career opportunities.
Smart to make a difference.
Smart to pursue economic sustainability.
Smart to enable change.
Smart to provide public service.
I say to you today, if you have a love for people, if you enjoy nurturing your communities and taking care of persons, then definitely the Barbados Police Service, of which I am a proud member, is the place for you. So I encourage you, lend us a hand, join us now to help keep Barbados safe.
Come join us, join me in making our country a safer Barbados.
Your place is here in the Barbados Police Service.
Come, join our ranks and chart a career of economic sustainability. Make that difference as an agent of change while providing public service as you fulfill your life's dream.
Welcome back as we continue our chat with podiatrist Miss Simone McConnie. Now, in the first half, Miss McConnie, we would have looked at what podiatry is, some of the conditions affecting the feet, etc. I know the major patient you see is somebody with diabetes.
Correct.
Let's look at the diabetic foot.
Where do we start? So, I think, first of all, I'll start by just saying that diabetic foot disease is significant on the island, not only in the island, but across the region. And I think over the years, it's still not 110% understood. The only way scientifically proven, documented internationally, is to manage the diabetic foot with a multidisciplinary team. So a multidisciplinary team may have a podiatrist, as they call podiatrists gatekeepers, because we spend a lot more time with our patients. When a patient comes in to see us, we're not just asking them like why you're here. We are managing them. So we pick up risk challenges early on. We would have screened our patients to identify whether they are neuropathic. So neuropathy is when you've lost sensation in your feet. We would have screened them to look at whether they have loss of circulation, so circulation challenges. And if you don't have a good blood flow to your foot, then you are actually at risk of a problem. And there are people walking around with poor circulation, poor arterial circulation, and I will define that there because it is very common that I see patients that say, my doctor told me I have poor circulation. And then they're like, okay, what is it though? Is it poor vascular circulation, poor arterial circulation, or poor venous circulation? And they shouldn't be mixed up because the deficiency in both are slightly different things. Patients can have both, so you can have arterial and venous. But when we're talking about diabetes, and even you're diabetic, you can have venous challenges as well. So we're looking specifically at the complications of diabetes, and we're looking at the nerve damage and the circulation challenges. Then we also have to look at the deformity to the feet. And deformity of the feet come also with what we call ligamentous laxity. So you get the ligaments of the foot loosen a little bit over the time. You get complications with regards to how the nerves communicate with the vessels, communicate with the joints, and you can get something called Charcot arthropathy, which is where basically when you look at it on an X-ray, it looks as if a bomb exploded in your foot. But really and truly, it would have been coming on for a while. You know, someone may present with just a warm, swollen foot. So like, for example, today we saw a patient who had been to her doctor, but he didn't seem concerned about her foot, tell her that she may need to wear varicose stockings. She came for another opinion because her left foot was swelling. She's diabetic for 15 years. Never really been educated on her diabetes, so looking at examining her feet on a regular basis. So examining your feet is something that we have our patients do, and we like our patients to be identified, for them to know, do I have good circulation? Do I have poor circulation? Footwear, advice, etc. So because we're so engaged with our patients, we tend to be known as the gatekeepers because we pick things up a lot earlier than a general practitioner may. So a general practitioner may see a patient and they're seeing them to replete their medication, check everything else about their body, and they may screen the feet by checking the pulses, etc. But they may not see it in the same way that we do. So this lady actually was sent off to have some x-rays done because she had warm temperature, swelling of the feet, swelling of the limb, discoloration of the lower third. So yes, she fit the buck of a venous disease, but when we further investigated, she actually has Charcot. So now we have to put her in a boot to stabilize her, and that will be a boot for 6 to 8 weeks. Some people have gone to 10 weeks. But it is about taking the load off the joint so the joint does not become further destroyed, and giving the joint an opportunity to heal itself. And what will happen is the joints may not go back in cohesion as they were, but they can get back strong. And there's a lot of science around studies around looking now at like vitamin D and the effects of bone vitamin D on these diabetics as well. But when we're looking at the diabetic foot, because it's so there's so many facets to the diabetic foot, we need to have a vascular surgeon, we need to have a podiatrist, we need to have your general practitioner or your endocrinologist or whoever is managing your diabetes. We need to have a nurse practitioner or someone who's able to see and have a relationship with you. Because think of it, you walk into a doctor's office, they tell you you have diabetic foot disease or whatever. We throw 1,000 things at you. You've got all this medication going on. Psychologically, you've got so much going on. How much of it are you actually taking away from you? How much of it are you actually doing?
So let me ask you this. I'm a diabetic. What should I look for in terms of any changes to my feet?
Anything. So before, we used to be indicating things like color changes, being specific, or temperature changes. So right now, temperature changes have come to the top of the list of what you should be looking at. So you should have a good feel of what your temperature of your feet are, and when that temperature goes up, you should be thinking that there might be a challenge. The challenge we have in Barbados is we're always hot. Mm-hmm. So sometimes it's a matter of really knowing your body well enough. Examining the soles of your feet, doing it on such a familiar basis that when there's a small change, well, you know what, that dark mark, red mark, orange mark, green mark, swelling, whatever, that change was not there yesterday. So it's knowing your feet. I mean, I always liken it to if you went somewhere and opened the door and it had ink on the door and you got a little print of ink on your finger, within seconds you'll notice, got ink on my finger. But if you're not looking at the bottom of your foot, that same shoe or whatever that put a little bit of ink on your foot, it may take days. We've had people come in with shoes with a tack going right through up into their foot.
And they didn't know.
Yeah, and things like tacks are actually an emergency. So if you've got punctured with anything, because you need to think about the fact that that tack is lying around in dust, and that tack has now punctured you, so that dust has been implanted deep down in your tissues. And if you're diabetic, you actually have a slow response to these things. So overnight, you can then have a swollen, warm foot. So this is why the warmth of the foot has become something that, is merited as a good sign of there might be an issue, for early detection of there being an issue with your foot. And you can seek a podiatry opinion early on. And with regards to, that from a medical emergency, that patient should be seen in a timely manner. They shouldn't have to sit around anywhere. So we know we've had challenges with our emergency recently, but they shouldn't have to then go and sit in ER for 48 hours. I personally feel that we are small enough as a country that we can have a medical diabetic foot emergency center. Because of the high rates of amputations that we have, not only in Barbados, but across the region. I've done work across the region as well. And every single island thinks that they're the amputation capital of the world. Every single island. And it's because we don't really have proper policies, protocols in place. It should be standardized. If a patient presents with X, you do Y. It should not be a a guessing game, and it shouldn't be dependent on which practitioner sees them. It should be formalized by government, by Ministry of Health. You know, when a patient is seen, this is the standard of care.
I want to go back. I want to be clear on what you just said. You are saying we are at a stage in Barbados where we need a dedicated emergency room clinic for diabetics regarding the care of their feet.
It should be an emergency when a patient turns up at the hospital and they're identified as having a diabetic foot problem. There should be some emergency process. They're not sitting there for 12 minutes or hour, or they should be seen right away, and they should be managed right away. It makes a huge difference with regards to the outcome of that patient, with regards to how quickly they're managed. There's some things that can take time, but there's some things that should be managed a lot faster than we do right now.
We are averaging at a minimum, I believe, about 200 amputations a year.
So, you know what? Again, for 30 years, it's all been anecdotal, because it's been, this person has done this study, this have found 200 amputations a year. But my thing is, has it actually made a difference? Do we really care about the fact that we have high amputation rates? I don't know. I'm a little confused, and I would love someone to explain it to me. Because if I know that, you know, we saw COVID. Look at how we managed COVID. We managed COVID where all hands were on that. It was an emergency. And we put policies in place, implemented standards of care. This is how it is. Why can't we do that for the diabetic foot? Why do people have to suffer? My problem isn't really all of that. My problem is when I see the suffering. And I could tell you a story of, you know, I have a patient who, he was admitted with a lesion on the outside of his fifth toe. And he was in hospital for about 4 or 5 weeks. And they got to a point where they told him that it wasn't healing and he needed to have an amputation. And he was scared. He was a university lecturer. And he was like, well, if I have an amputation, how am I going to go back to work? And he came at my door, and I'll never forget when he came through my door, he had that fear in his eyes. And I said to him, well, you know, I don't know that I can help you, but I will try. I will do my best. And if I can't, I will find someone that can help you. Even if that means that I have to send you overseas. Are you open to that? He said yes. So he came in, and he will tell you the story today where he'll say, Ma, I didn't know if to trust them or you. But he had a doctor call him every day because he discharged himself from the hospital. He came to see me as I don't know how he got out, but he came to see me while he was still in hospital. Then he went back into hospital and he discharged himself, and he started coming to me, and he said to me, so a doctor from the hospital called him every day and said, you need to come in and have that foot amputated. If not, you're going to die. And he said he didn't know. He was scared. And I told him, that's not a decision I can make. I am not God. I am not here. I'm not better than anyone. I'm just following the standards, the protocols that have been executed internationally. And we'll see how it goes. And he improved. He never had his amputation. He does have a deformed side of the foot because it's healed, where we did have to take sequester of bone out because he had osteomyelitis, which is infection of the bone. If you have an infection going on long enough, it can go to the bone. Piece of that bone came out. He now has where his fifth toe sits kind of slightly on top of his fourth toe, but we would still say he has 10 toes and he has 2 feet. So one day he went back to the hospital because obviously he's maintained going to the hospital for his medical attention, etc. And one day he walked in and the doctor said to him, oh, that's a wonderful prosthetic limb you got there. Where you got that limb from? And he said, well, I don't even want to tell you what I felt like saying. So I say this story not to be offensive to anyone. I say this story because I'm confused. My confusion comes from what you just said. You know, we have these high amputation rates. But yeah, after 30 years, I'm not sure that I see a lot of changes that show or indicate a caring for these people and for their suffering. Like, you know, when you think about it, if I told you stand up here and let me cut your foot off and send you home, how does that solve your problem really? Because now who's cooking and cleaning for you? Who's looking after your from a social perspective? When you wake up in the middle of the night, you got diarrhea, you go to the toilet. How are you getting into that? Like, you know, are you taking any of these things into consideration? And if you've lost a limb already, should you not be thinking, okay, well, what can I do to make sure this patient doesn't lose their other limb? I have some double amputees, you know, and some of them are, I would say that there are some amputations that are needed. But I would say if we have these proper protocols and standards in place, we can cut our amputations by 50%. And 80% of amputations, so 15 to 34% of patients that are diabetic will present with a diabetic foot ulcer. But 80% of those can be prevented if you have the right program in place.
And it comes down to personal education as well, in terms of persons knowing, as we were discussing before, what to look for and seek attention early, because that's the thing.
But my problem now I'm getting is that, especially with my colleagues, I mean, all of our practices are full. And, you know, I have an emergency here in my office, and I work with various doctors and other people who work with me, because I'm no longer about begging. I think after 30 years, I shouldn't have to beg a doctor to see a patient. I'm not doing it for myself. I'm doing it for the patient. And it's actually very heartbreaking when that is where you get to. But my reality is that if you're going to make sure that that patient maintains maintains their feet, then what else? Hands are tied. You know, what else do you do? So I feel we just need to work a lot more cohesively, a lot more collaboratively, and not be offended. I'm not better than anybody else. All I'm doing is following the standards. So all I'm saying is follow the standards, and you know, we can all work together as a team.
And like I was discussing before, in terms of people making personal choices off camera, we were talking about the dangers of women wearing nail extensions, for instance.
Oh my goodness, yeah. So whether you're diabetic or not,
right.
You know, I'm not sure, but you think about it. Gel nails has become a real in thing, but they really are heavy on the nail. And some people have thick nails or thin nails, and a lot of women like to wear the extensions on their toes. But then they have the extensions on their toes, and then they're having these scrushed up shoes. So they don't go together. So we do see a lot of challenges where the gel nails have damaged the nail, caused a fungus, caused the nail to lift up, caused bacteria to get under the nail, and you know, some people will come in and say, oh, well, my nail was green. It was green because the nail was lifted up, maybe from wearing a bad shoe. The moisture got under there, and then as a result, it either got that infection. So the nail needs to actually be removed, or it needs to be treated or combined, depending on what the challenges is. So I'm not a fan of the gel toenails either, because I do find like gels on the fingernails, okay, I give you that, because when you put nail polish on, that may last a very short time. You're doing washing up and stuff. But really and truly, toenails last long. So why do you need gel on them?
Gel lasts longer.
But you shouldn't have nail polish on for more than 2 weeks on your toenails.
Really?
Because it damages the nail bed and the nail plate. So some people take off their nail polish, and they say, oh, my nails have gone yellow. Some of it comes from the staining of the type of nail polish you're using as well, because some of the nail polishes have in a lot of agents that are damaging to the nail, dries out the nail, and then the nail polish remover itself also damages the nail. But having said all of that, like, you know, why do you need to have nail polish on your nails for more than 2 weeks? And you should go through a point where you don't have nail polish on at all. Give your natural oils and the nail plate and the natural oils of your body to nourish the nails. So you won't get that if it's blocked by the nail polish.
Outside of the diabetic foot and all the other conditions affecting the feet that we've discussed, what is one of your major concerns in terms of what you're seeing?
Well, I think, to be honest, I just feel that as a health practitioner in Barbados, it's been very difficult clearing the waters and getting into practicing as a podiatrist. You spend 30 years of trying to prove who you are, what you're capable of doing. And I find it hard when a doctor 30 years later says to you, what do you actually do? Those are a little challenging for us as podiatrists. And I think the cohesion of the healthcare practitioners in general working together, there's a missing link of team, what team really means, what does a multidisciplinary team mean? Also are importing things, you get customs challenges. Customs say that they're not there to get in the way of your business. But at the same time, I've had scenarios where I bring in a pair of diabetic shoes or orthopedic shoes for a adult patient, and I'll be told, well, I have to pay X amount of duty because it's a pair. And I'm like, well, most people have 2 feet. I can't bring 1 shoe. So it's like a lot of misunderstandings and miseducation as well with regards to what we actually do. And, I have some people with diabetic feet that cannot go into town or buy a standard pair of shoes because they've had a piece of their foot off or a piece of their toe off. So insurance companies as well, giving some of our patients challenges with helping to cover the cost. Internationally, if you're using international insurance, we have some footwear that we carry that are on the insurance scheme. So they get like 2 pairs of shoes, as under their insurance policy or health insurance policy as prevention. So I'm not sure why there's a disconnect with how we do some things here in Barbados. And I have a podiatrist who's just joined me here at Comfeet, and he's from the UK. And one of the other challenges he has is why are there policies for podiatry not in place after so long? Things like, if I do an ingrown toenail surgery, then why do I then have to refer a patient to a doctor to get time off? Why is it that a patient, you should be able to give the patient a day or 2 off work post-op, treatment, the ability to prescribe medication. Some of us are prescribing podiatrists. You're not able to do so. Surgical podiatrists have no place in Barbados yet. There are no policies or laws to register them. Because the thing is, the confusion is we have podiatrists, we have podiatric surgeons, and then we have podiatry assistants. So it is, do we now need to be formulating maybe something like dentists so that we have a regulatory body specifically for podiatrists? Podiatrists right now are registered under the Paramedical Council, but the Paramedical Council cannot register someone to do surgeries. So, it's kind of like, why are we fighting this? Like it's called expansion. I know of 2 podiatrists who want to come and work here, and one is he wants to come because his wife is working here, but he can't because he can't practice as a podiatric surgeon because there's no registration bodies for him. So those are the things that are concerning, because if as a country we're trying to make life better for patients and make them easier, then those are obstacles that get in the way.
So you don't think that the field of podiatry is given the respect it deserves?
It's not given the respect, and we don't have enough.
Ms. McConnie, it has been a pleasure. Thank you for your bluntness. I appreciate everything that you've shared with me and members of the public.
You're most welcome, and thank you for inviting me. It has been a pleasure as well.
It has been a pleasure indeed. Thank you so much. That was podiatrist Miss Simone McConnie. I'm Lisa Lord. Thank you so much for watching One on One. Do have yourself a wonderful evening.